Good morning. Welcome again to the RMSG Symposium. I am Professor Naila Rabbani from the College of Medicine, Qatar University, Doha, Qatar. I am introducing the background and data from the Healthy Aging Through Functional Food HATFF Study. It is a phase 2A clinical trial of glyoxylase-1 inducer for correction of insulin resistance in overweight and obese subjects. Glyoxylase-1 inducer were developed to treat dicarbonyl stress. Dicarbonyl stress is the abnormal accumulation of dicarbonyl metabolites leading to increased protein and DNA damage, contributing to cell and tissue dysfunction in aging and disease. A common reactive dicarbonyl metabolite is methylglyoxal, produced mainly as a byproduct of early-stage glycolysis with increased formation in hyperglycemia. Methylglyoxal is mainly metabolized by glyoxylase-1 of the glyoxylase system. It is a cytosolic glutathione-dependent enzyme system catalyzing the detoxification of methylglyoxal. Methylglyoxal was initially studied in clinical diabetes where a 4 to 5-fold increase of Mg was found in blood samples of patients with type 1 diabetes and 2 to 3-fold increase in patients with type 2 diabetes. Terminal product of Mg metabolism by the glyoxylase system is D-lactate, and this is a surrogate marker of flux of Mg formation. Plasma D-lactate was increased about 2-fold in patients with diabetes. Mg has a greater increase in diabetes than D-lactate because there is also decreased Glo1 activity in selected tissues in diabetes. Increased Mg formation and decreased Glo1 activity synergize to produce the large increase in Mg. A similar effect is found in overweight and obese subjects with a smaller magnitude of change. This slide shows the gradation in severity of dicarbonyl stress in different physiological states and disease. Plasma Mg is increased about 2-fold in subjects with obesity, 3 to 4-fold in diabetes, and 4 to 5-fold in renal failure, causing mild, moderate, and severe dicarbonyl stress, respectively. Most of Mg is a byproduct of metabolic pathways, glycolysis, gluconeogenesis, and glyceroneogenesis, and considered to be a proteome poison, analogous to formation of ROS as a byproduct of cellular respiration. The endogenous flux of formation in healthy human subject is about 3 millimole per day. 90% of total flux come from these pathways. A small amount of Mg is also produced through threonine catabolism, protein glycation, food and drink, and ketosis. Now, what does Mg do? It reacts mainly with arginine residues in proteins to form the major advanced glycation end products, methylglyoxal-derived hydroimidazolone, MGH1. It also reacts with deoxyguanosine residues in DNA to form the imidazopyrinone adduct, MGDG. This is the major adduct formed by spontaneous modification of DNA. Glo1 of the glyoxylase system metabolizes and maintains Mg at low levels such that protein and DNA modification is suppressed to low tolerable levels. This is changed in obesity and diabetes. A key consequence of MGH1 formation is change of a hydrophilic arginine residue to a hydrophobic MGH1 residue. This produces misfolding of proteins and activates the unfolded protein response called ER stress in the endoplasmic reticulum, and is a driver of low-grade inflammation in obesity and diabetes. So is MG and Glo1 important in obesity and insulin resistance? Some genetic studies support a link. In human subjects, Glo1 is linked to upper arm circumference and suprailiac skin fold thickness, reported by Wilson et al. In 1991, and quantitative trait loci studies found an association of Glo1 to body weight in mice, reported in 2006 by Washek et al. For functional genomic, Mason et al. Studied Glo1 overexpressing transgenic mice on a high-fat diet and found Glo1 overexpression protected against body weight gain, adiposity, development of an inflammatory phenotype, and insulin resistance. Then in a clinical therapeutic, we performed the HATFF study, and an inducer of glyoxylase 1 expression corrects insulin resistance and improves vascular function in overweight and obese subjects, which I will describe in detail later. In clinical overweight and obese subjects, there was a progressive increase in plasma methylglyoxal from lean to overweight to obese subjects and an increase in plasma D-lactate only in obese subjects. This suggests that decrease in Glo1 activity may occur in overweight subjects, and both increase in Glo1 activity and increase in MG formation occur in obese subjects. We considered how it may be best to produce pharmacological agents to decrease MG clinically. Inducer of Glo1 expression was preferred because Glo1 inducer remove MG catalytically with maximum efficiency, and Glo1 inducers correct the functional deficiency of tissue-specific decreased Glo1 expression or protein in diabetes and obesity. Other approaches tried have been MG scavengers such as aminoguanidine and PTB and age breaker and arginine-rich peptides. They have difficulties in implementation, although AG and PTB have high reactivity for effective scavenging, but this was linked to toxicity and half-life and short half-life for AG, and short half-life and instability for PTB. So inducer of Glo1 expression or Glo1 inducers were considered the best approach. To develop Glo1 inducers, we examined potential promoter elements to exploit, and we discovered the antioxidant response element. We validated it and published in 2012. Small molecule activators of NRF2 led to NRF binding to Glo1 antioxidant response element and inducing increased Glo1 expression. To screen Glo1 inducers, we developed a stable transfectant Glo1 ARE luciferase reporter cell line and mutant control for functional Glo1 transcription inducer assay. So we screened dietary bioactive compounds as a potential source of Glo1 inducers of known high clinical tolerability and low risk of adverse effects required for a prospective treatment of complications of obesity and diabetes. The outcome was the compound with highest maximal response, Emax, was trans-resveratrol, and compound with the lowest median effective concentration EC50 was hesperetin. We were concerned that a pharmacologically active concentration of TRES could not be achieved clinically, and that the maximal effect of hesperetin would be too small for high efficacy. So we therefore studied the effect of combining Tres with hesperetin and achieved a Glo1 inducer combination active over clinically achievable concentration of Tres with high maximal effect. The combination had up to about 84 synergy over clinical concentration range, and this was taken forward for phase 2A clinical trial with regulatory approval. The combination of Tres with hesperetin overcomes the bioavailability barrier to Tres. Clinical translation of therapeutic benefits of resveratrol have previously failed due to poor availability linked to glucuronidation in the small intestine. This is overcome by Tres-HASP combination. At doses of greater than 30 mg, hesperetin is an effective inhibitor of intestinal glucuronidation, facilitating uptake of conjugated hesperetin and concurrently T-resveratrol. For the clinical study, we designed a crossover study in overweight and obese subjects with endpoints of metabolic and vascular health. The study design was a randomized, placebo-controlled, double-blind crossover study with 8 weeks treatment and 6 weeks washout period. We recruited 32 subjects. The dose was 90 mg Tres and 120 mg hesperetin given once daily in oral capsule before breakfast. The clinical endpoints were metabolic health, oral glucose tolerance test derived insulin resistance measure, OGS index, and vascular health, brachial artery flow mediated dilatation, and subtherapeutic glyceryl trinitrate was measured. The study was completed in December 2014 and registered on the clinical trial website. Here are the subject characteristics. 29 patients completed the study, 18 were overweight and 11 obese. Only 9 had prediabetes. Safety assessment of Tres-HASP combination showed that it was highly tolerated, given normal liver function, hematology, and immunology markers. For target validation, we measured Glo1 activity in peripheral blood mononuclear cells, which was increased 27% post-treatment with Tres-HASP and not changed with placebo. And we measured plasma Mg level, which was decreased 37% post-treatment with Tres-HASP and not changed with placebo. Now, looking at the endpoint, most changes were found in highly overweight and obese subjects with BMI greater than 27.5. Fasting plasma glucose was decreased 5%, and postprandial glucose area under the curve in the 2-hour OGTT was decreased 8%. Insulin sensitivity was measured by the oral glucose insulin sensitivity index, OGIS. It was profoundly improved, plus 42 in overweight and obese subject and plus 58 in obese subjects, indicating that insulin sensitivity was corrected to that of lean controls. Vascular function there was improved flow-mediated dilatation and decreased inflammation as judged by decrease in plasma-soluble ICAM1. For renal function, there was a small 3% increase in EGFR and 9% decrease in plasma urea. Subjects had stage 1 and 2 chronic kidney disease. So there was no effect of placebo. So Glo1 inducer is safe, exhibits target Glo1 inducer is safe, exhibit target clinical pharmacology, and outperform treatments in overweight and obese subjects. So that, as I said, that in obese subject, TDES has increased OGS by 58 units. How does this compare with other intervention in obesity? For bariatric surgery, 6 months post-gastric band surgery and extreme weight loss, there was an OGS increase of plus 62 units. And in patients with type 2 diabetes, a high dose of metformin, 1.7 gram metformin, produced an OGS increase of plus 54 units. So TDES is producing a pharmaceutical level effects, but TDES has increased OGS is driven mainly by improved fasting plasma glucose and postprandial plasma glucose. We also performed a focused gene expression array analysis in PBMCs. Relative mRNA copy number was measured by nanostring analysis at baseline and post-supplementation in treatment and placebo arms. There was no change with placebo. Interleukin-8 was decreased 39% and COX-2 decreased 30% in all subjects. In highly overweight and obese subject, MCP1, monocyte chemoattractant protein 1 was decreased 49%, and the receptor for advanced glycation end product decreased 37%. Decreased MCP1 and IL-8 expression by TRES-HESP may be a downstream effect of improved insulin sensitivity rather than an upstream mediator of it. In previous clinical studies, adipose tissue level of MCP1 and IL-8 were increased by hyperinsulinic clamps. In correlation analysis of glyoxylase-related variables across the two arms of the study, there were negative correlations of PBMC Glo1 activity with plasma protein MGH1 and plasma D-lactate, suggesting that the increase of Glo1 may suppress both protein glycation by MG and, after improvement in metabolic health, flux of formation of MG as well. For clinical variables, BMI and area under the curve for glucose correlated positively with plasma D-lactate, and the OGS index correlated negatively with plasma D-lactate. This suggests that flux of MG is positively associated with dysglycemia, insulin resistance, and BMI. For vascular inflammation markers, plasma MCP1, soluble VCAM1, and soluble ICAM1 correlated negatively with PBMC Glo1 activity, and plasma soluble E-selectin correlated positively with plasma D-lactate. For blood pressure, cytosolic and diastolic blood pressure correlated positively with plasma Mg concentration, diastolic blood pressure and plasma endothelin-1 correlated negatively to PBMC Glo1 activity and positively with plasma D-lactate. For variable of clinical dyslipidemia, HDL correlated negatively and LDL, VLDL, and TG positively, triglyceride positively with urinary MGH1. It's a measure of total body MG glycation. And plasma D-lactate correlated positively with total cholesterol, LDL, VLDL, and triglyceride, and negatively with HDL. This suggesting Glo1 expression may have health benefit through decreasing vascular inflammation and improving hemodynamic and dyslipidemia. To assess PBMC gene expression changes linked to pharmacological responses to Glo1 inducer, we performed correlation analysis of genes with expression changed from baseline in Glo1 inducer treatment period. Exploring the correlation of change in PBMC gene expression with clinical and metabolic variables, we found change in Glo1 expression correlated negatively with change in area under the curve, shown in A, and change in thyrodoxin interacting protein TXNP correlated positively with change in area under the curve for glucose, shown in B. TXNP is a mediator of insulin resistance in liver, skeletal muscle, and adipose tissue, and impair pancreatic beta cell insulin secretion. So change in expression of tumor necrosis factor alpha correlated positively with change in fasting plasma glucose and negatively with change in OGS. Therefore, health improvement by Glo1 inducer was linked to two established mediators of insulin resistance, TXNP and TNF-alpha. For the mechanism of action of Glo1 inducer TRAS-HATFF combination, we propose activation of transcription factor NRF2 and thereby induction of glyoxylase-1 expression. Increased Glo1 expression and activity decreases Mg, decreasing formation of misfolded Mg-modified proteins and preventing activation of inositol requiring enzyme 1-alpha. This decreases degradation of microRNA 17, which in turn destabilizes mRNA of TXNP and decreases TXNP expression and insulin resistance, particularly maintaining GLUT4 function. Decreased action of XBP1 by IRE1 alpha and the NLRP3 inflammasome by TXNP, this is the topic of a short talk 825 at this meeting, will prevent expression of inflammatory mediators IL-8, MCP1, COX-2, RAGE, and TNF-alpha. This maintains skeletal muscle glucose uptake, beta cell mass, and insulin secretion and decreases hepatic gluconeogenesis. Resveratrol and hesperetin administered individually in previous studies were ineffective. From meta-analysis, it was concluded that TRAS does not affect glycemic status in overweight and obese human subject. This is at odds with evidence from rodent models and is likely due to interspecies differences in pharmacology, host interactions, and maximum tolerable dose. Claimed benefit of resveratrol in diabetes have not been reproduced. There was no effect with 500 mg per day. This was published by Bo et al. In 2016. The success of resveratrol-hesperetin combination is due to synergism at multiple levels. First, bioavailability. As I mentioned earlier in this presentation, hesperetin blocks intestinal glucuronidation and acts as a carrier for resveratrol uptake, overcoming the clinical bioavailability barrier to resveratrol. And second, the synergism in activation of NRF2. NRF2 is a translocational oscillator requiring both increased oscillation frequency and slowing of inactivation in the nucleus for a trans-activational activity. It is likely that hesperetin increases oscillation activity by activation of protein kinase A upstream of oscillation regulator fin kinase. And in the cell nucleus, NRF2 slows inactivation of NRF2 by acetylation through activation of deacetylase, SIRT1. So activation of protein kinase A also activates SIRT1. So there is also synergism in activation of SIRT1. A treatment of insulin resistance is much needed. Insulin resistance is a major risk factor for the development of type 2 diabetes. It is also a risk factor for non-alcoholic fatty liver disease and linked to chronic kidney disease, decline in respiratory function, cardiovascular disease, and all-cause mortality. With a safe and effective treatment of insulin resistance, prevention of type 2 diabetes and other insulin resistance-linked pathology could be improved. With the limited clinical use of glutazones due to several adverse side effects, there is currently no pharmacotherapy specifically targeting mechanism of insulin resistance. Glo1 inducer as a route to novel insulin sensitizing agents are an encouraging step forward. In summary, dicarbonyl stress is a common feature of obesity and diabetes, increasing in severity from lean, overweight to obese, and increases in diabetes. It is linked to insulin resistance, likely through increased MG-modified protein activation, the UPR-ER stress with increase of TXNP and low-grade inflammation. Glo1 inducers offer a safe and effective intervention to counter dicarbonyl stress clinically, and Glo1 inducer corrected insulin resistance and decreased vascular inflammation in phase 2A trial in overweight and obese subjects. So Glo1 inducer offers a new treatment option in development for reversal of insulin resistance and prevention of type 2 diabetes. I would like to thank the investigator team, long-standing collaborators, Dr. Paul Thonelli and Dr. Ming Zhang Zhu in QBRI, and the Qatar Foundation and Qatar University for funding our research. And finally, I also thank you so much for listening. Thank you.